with that, actually, I think it's time we go on with our first speaker, who will be a stranger to none of you. Delighted to have Professor O'Sullivan, who tells me that the Puma team were the first people to call for routine videolaryngoscopy. As I pointed out to many, I've been doing routine videolaryngoscopy long before they called for it. But I'm going to sit down over here and let Professor O'Sullivan talk to you all.
Thank you very much. I work in Dublin in St James's Hospital. I just put that in to say we do a lot of difficult airway management, and we do have great availability of videolaryngoscopes. We have McGuire's for anybody who wants to use them, some CMACs and some hyperangulated blades, and we also use the channeled videolaryngoscopes. So that's kind of routine in our hospitals. Now, these were mentioned today, so I'm not going to talk too much about them. And two of the authors are here, Nick and Andy as well. And just to say that the group that did the guidelines were a group of 11 anaesthesiologists, but there were 3 intensivists in the group, and I think that's important, and 3 emergency physicians, and coming from the 4 continents of the world, which I think is relevant when we come to the recommendations. And we heard all about this today from Andy and Nick, so I won't go over it, but we defined the criteria for sustained exhaled CO2. And we have a set of 11 recommendations, and the second recommendation is routine use of a videolaryngoscope is recommended whenever feasible. So just to stress that. And I thought we were the first guideline to say that, but the Canadian Air Force, I think, got there before us. But what evidence did we use for that? There were loads of studies, but remember the Cochrane review came out in 2017, so I won't go before that. And that looked at VL versus DL. And as always with Cochrane reviews, it was on the fence a little bit, but there were a lot of studies included, 64 studies of dubious evidence-based, and over 7,000 patients. And they supported the fact that the evidence supported, should I say, a reduction in the incidence of failed intubation. So that was kind of, the take-home message. But the evidence for the glide scope, the Pentax airway AWS scope, the channel scope, and the McGuire 5, the older McGuire wasn't there, although there was some good evidence for the CMAC. They also said in their conclusions that they found no evidence to indicate that the use of a VL would result in fewer attempts at intubation. And they did not establish whether intubation is likely to be less or more time with a VL, or whether it resulted in fewer instances of hypoxia or respiratory complications. So again, not great evidence. And they made the usual comment that we're missing quality data to come to definitive solutions and answers. So that's where we stood for a few years. But, and these were the limitations. VL requires training for proficiency, and any of the benefits that were obtained were only obtained if you were trained and experienced. If you were an inexperienced user, you didn't gain those benefits. But hey presto, another one came out recently, the Cochrane Review in April 2022. So that was fantastic. This is Jan Hansel, the main author of that paper. And this time there was a major change in that they put the videolaryngoscopy classification together. So they classified them into MAC style, hyperangulated and channeled. Okay, and then they looked at lots more studies. There were 222 studies included in this, so much more studies, huge number of patients, not just 700, 149 patient participants. So this is a huge review. And their conclusions in a nutshell: MAC-style VLs, less failed intubation and hypoxia, and higher success first pass, which is what we're all interested in, isn't it? And then with the hyperangulated VL, less failed intubations and esophageal intubation, and higher success first attempt. So this is recent data, and as I say, big numbers of studies and big numbers of patients. So in our recommendations, use VL whenever feasible, and the airway operator should verbalise the view at laryngoscopy. And I think this is very important. And we stress this as well in the valid alternative techniques we mentioned today. When you're doing your repeat laryngoscopy, make sure you can see with your videoscope the arytenoids. You can see you know, the epiglottis, you get a good view, and you do a deliberate laryngoscopy. You look at pharyngeal structures, you look at the laryngeal structures, and you don't just push the tube in. And that's the two. And you avoid glottic impersonation. Now, this is a picture we got from one of our colleagues on the group, and he's published on it. But this is a view you might go if you just rushed in, put the videolaryngoscope straight in. Number two, it's the view with a limited view. And with DL, you get a more limited view, you know, than you do with your videoscope, which is a much wider angle. So look, that is actually the esophagus, and that is your larynx. So I think that's a very good illustration, which we got from George Kovac, of glottic impersonation. And this stresses the deliberate observation of your tube placement. So we must be more careful when we're using these instruments and be more deliberate in our intubations. And again, just quickly going over this, but you see the hatched bars. These are probably the views you get with your DL, and you can easily miss your arytenoids, particularly if there's abnormal anatomy. It doesn't come out very well here, but it's in the PUMA document. This picture, I think, isn't it, Nick? Yeah, it's in the documentation. So it's worth looking at these images, and you can see why. These are all esophageal intubations, but actually, if you look carefully, some of them very much look like the laryngeal inlet. So I think be very careful. And that's probably what happens in some of these, sadly, these unrecognised esophageal intubations. So as I say, we also emphasise in the guideline the role of the assistant observing the view. So that's the advantage of VL, is that everybody in the room can see the view, and confirming the presence of sustained exhaled CO2 and adequate SpO2. So what are the human factors again? Just to remind us, reduced esophageal intubation twofold from that study, the Cochrane review. It reduces difficulty, improves quality of view, and depth of view, enhances team training, and improves first pass success. We now have the evidence for that. And so back to the DAS. It's a DAS meeting. I have to mention the DAS 2015 guidelines. And we recognised back then our first plan A was optimise success and first attempt at laryngoscopy. So right back then, I think it was the first time the kind of first pass success term was coined, the importance of it. And that's why we wanted to limit attempts, because the more attempts you do, the more stressed you get, the more you cause, we'll say trauma seems a strong word, but the more damage you cause, human factors go out the window. And this is Paul Baker demonstrating fixation error. Doing the same thing time and time again doesn't give you a different result. So human factor advantages you can see in this scenario in A&E, where, you know, the assistant is looking at the view. She's giving a bit of cricoid pressure to the intubator. Also, in fact, this person is also looking at the view. So everybody, hopefully not too many voices, but that somebody is, you know, helping and directing, particularly the assistant, I think. And we must educate our assistants. We must show them what we're looking at, describe what we're looking at, so that the next time they see it, that they'll know what we're looking at. So guidelines emphasise, as I say, the role of the assistant in observing the view and confirming sustained exhaled CO2 and SpO2. Assistant needs to have both expertise and empowerment. And how do we do that? By training them. They're not just handing us pieces of equipment. We're training them every time we intubate. We can train an assistant, can't we? And you might have them the following week, and that is great. And then empowerment is that we can kind of change them to challenge us. Did you see CO2 or not, and so forth. So I think it's about empowerment and expertise. So thank you very much. And just also to mention, it wasn't just us, these group from the four continents, from different airway societies, from emergency medicine, intensive care. All these societies have endorsed this guideline. So they've endorsed the fact that we should use VL, in my opinion. So that's where we're at. And I think Nick might tell us, but there are more organisations in the pipeline that are going to endorse those guidelines. So again, routine use of VL whenever feasible. So I rest my case. And what will we do in the next guidelines? We wait and see. This is Al and Andy, who are both here, and this is our second face-to-face meeting of we're redoing the DAS intubation guidelines. Hopefully we'll have them by 24, 25, Al? 25. Okay, so thank you very much. That's all I have to say. Thank you.
So while we wait for a little bit of technical transition, that lets me ask the crowd. If now there is a paper calling for routine videolaryngoscopy, how many of you would class yourselves as routine videolaryngoscopists? Excellent. So I think we've got more than half the room. I guess the challenge is to have the whole room by the time you all go back to work at the end of DAS. Our next speaker, hopefully, is my good friend Barry McGuire. Barry, as many of you will know, is a former DAS president. And when they saw the two of us standing together, they were originally going to call this presentation Big V Small. I cannot quite understand why they changed it. I think I complained. But Barry, delighted to have you with us, making us think.
Evening all. So that was a professorial talk. This is a jobbing anaesthetist talk. I'm the only non-professor. And it's, no, not that, the implication that, yes, okay. It's 6:15, so we're not going to give a talk, really. It's time for glasses of wine and a bit of interaction. So I'm not going to really tell you anything that you don't already know. So my remit was pixels versus portability. I'm sure you understand that title. Where am I pointing now? Okay, Matteo, who's that? Where's Matteo?
Oh no, you're putting me on the spot.
Anyone know who that is? God, you've got to get out more, guys. That's Filippo Ganna, okay? Probably the best time trialist in the last 10 years. Italian stallion. So the reason I'm putting it up there is his bike, everything in his bike is designed to be aerodynamic. Okay, so the bottle cage is aerodynamic. And usually he's taking the bottle out. They normally have the bottle in there, even if there's no water in it, because it makes the bike even more aerodynamic. Even his gel is placed in an aerodynamic way. So everything he rides, everything he's doing is about making him faster in a straight line. And he's not too bothered about the weight of the bike. This guy is called Andy Schleck. He's Luxembourg, about 10, 15 years. In fact, I was at this stage in Galibier. He made an amazing attack and won the stage. But he's bothered about the weight of his bike because he's going up 5,000 metres of climbing in a day. And his bike has to be built for climbing. So he's not really bothered about how aerodynamic it is. And you can see that there's not the same sort of design. Maybe you can't see if you're not a bike geek like me. But his bike is built for weight. And the rest of his kit isn't really aerodynamic. His helmet's not aerodynamic and so on and so forth. So this bike, I'm not sure what it's built for. Entertainment. I think the point is horses for courses. So not all devices are the same. And therefore, to compare them, to ask the question pixels versus portability is perhaps unfair. Getting to the boring bit, and actually Ellen's spoken about most of this already. So in which situations might you care about the quality of the image at VL? Well, definitely, Ellen's already mentioned human factors and ergonomics. So perhaps the better the visualization of the screen in terms of size and image quality, the better the team approach to videolaryngoscopy. The easier of teaching, the easier to view pathology, and many of us now involve our surgeons in VL, and the surgeons are still, most of my surgeons anyway, are still looking in a straight line and don't have video in ENT, and I'm always amazed that they're behind us really in that regard. I know some other places can look around corners, but most of the time they're looking in a straight line. So I've several times used videolaryngoscopy to help them put dilators in round the corner and all that kind of stuff. So airway pathology, I think, again, quality of image would be a benefit, would be an important factor there. Success, you might think that image quality is important to successful VL intubation. As far as I know, Alistair, that's not a fact that's been demonstrated in terms of outcome. So I would argue that image quality and success perhaps isn't an argument in favour of the very best image devices that you think, wow, look at the quality of that image. Yep, it's lovely, but does it really influence success? I'm not sure it does. Or I don't think we've demonstrated it. Versus portability. Again, dead obvious stuff. You all know this. Our pre-hospital guys in Dundee, they all use a small portable device. And they love that for pre-hospital. They use it for every single intubation. If I'm going somewhere that I think I might be intubating somebody, I'm going to be taking VL with me, and I'm unlikely to wheel down my nice big screen. I'm going to grab something portable. Speed. If you've got everything right there, if you've got Tim Cook's VL in place in every single airway management, then perhaps speed isn't an issue. Otherwise, I think portability and speed do go together a bit. Cost, I would have thought, is an issue for most of us, not for Professor Cook, but for most of us. And single use. When we looked at videolaryngoscopy before, a device, I'm going to keep everything nameless and generic, there was one device that was portable, that was single use in the UK that came out number one in terms of number of hospitals that had VL, they had this device. I'm not sure they were using it enough to be really skilled in it, personally, and I think it was a bit of a trick that everyone had bought this device because it was single use and therefore the cheapest. They didn't have to invest in lots and lots of expensive cameras, but I don't think they were using it enough to be skilled in it, so I think it was a bit of a fudge, to be honest. But you could argue that single use might be the way to go in this modern world of infection, and therefore portable. But in my view, we're never going to get consensus in this, and perhaps there's no need to get consensus. It's horses for courses. We might prefer one type of approach where pixels is most important in one scenario or certain scenarios and portability in others. Maybe a better question is, which VL technique or approach has the greatest impact on the most patients globally? And I don't think we have that evidence yet, and perhaps even that's not the right question yet. Maybe the right question is how many of us, as Alistair's asked, how many of us are using VL routinely in our practice? Perhaps that's the question at the moment, and that's for later on. All devices need to be as good as they can be in terms of image quality, price, accessibility, user-friendly, environmentally friendly. That's dead obvious. And I think that's me. And that is actually the bike you want. That's my bike. Thanks very much.
That's great. Okay, having had Irish Blarney, Scottish Spendthrift, we're going for Swiss quality to finish. I'm delighted that we have Professor Patrick Schoettker, who's Professor and Head of Department in Lausanne in Switzerland, finishing off, talking about teaching and education, because if you're a VL user like me, I get told by the trainees day in, day out, but if I use this all the time, I lose my skills in direct laryngoscopy. Anyone heard that? Oh my God. I'm sorry. Patrick, delighted to have you with us. Thank you very much.
Well, thank you very much. So, imagine they had to call in for a Swiss to give an answer to that kind of question. I mean, that sets the stage, right? So let me start with a question to you. Who thinks VL is deskilling DL? Raise your hands. Okay, I'm done. Your turn.
There was one hand.
So I have a small conflict of interest. I've introduced the VL in my department in 2007, and since then, everyone uses it all the times when I'm around. Which could also be called, it took me 15 years to realize that I miserably failed in what is evident, that using a device that allows you to share the view is the best available device for the patient's care, for the way we treat our airways, etc., etc. So that's something we need to remind you. And throughout the whole talk, this will be necessary for you to remember. The other good thing is, although this is Kishore Sandhu, my favorite ENT surgeon, he has changed from, there's a difficult airway, I will manage it, to, there's a difficult airway, Pat. You're going to do it very easily. When I do and have a look at it, it's all reread. So there is something that has changed over the couple 15 years that we've been using different devices, especially VL. We have gained the confidence of our ENT surgeons who actually get all the difficult airway patients as well. I was brought up by a generation of magicians of intubation. When nothing was possible, you could call the magician, he would do something called DL, and all of a sudden it was possible to achieve the goal. What he had done and the teaching experience was quite impressive because we were just stepping back and hoping he would manage, and he was probably just pulling a bit harder, pushing a bit harder, and then he managed it. And we've come to a time where the pseudo-expert is trying to teach, and the junior is telling the pseudo-expert how to manage it because he can't do it. And this is the life we live in, and this is exactly how it should be. We share the view, we get the input from everybody, and we maximize the efficiency by looking at everybody, understanding the airway, understanding the problem. I can't put the tube in, and you will see his finger say, hey, push it to the left side, and you will manage. Hey, do it. Oh, thank you, thank you. And this is the world we live in, and this is called VL, because we share, we understand, we teach, and we learn ourselves by doing that, by getting the inputs from everybody. When I introduced VL, everybody was saying, why do we need the different gadgets? Because we have been doing it this way, and this is how it works. I introduced it in April 2007, and we had a quick assessment of how was the difficult airway management done before, in blue, and after, and how is just the choice of the tools. And you can see that by using VL, we dramatically reduce the numbers of intubation with DL, we dramatically reduce the intubation with fibroscopes, and we change the practices in induction. So introducing new devices has an effect. Has it killed DL? I'm not sure, but it has changed the pattern of our experience with specific devices. So the question is cost. We've heard the cost. The true cost might be something else. We are losing some skills. We just need to understand and then compensate what we have lost by maybe doing some training. And I'll give you some inputs tomorrow during the discussion. This is the world's major event since 1943. Once the Macintosh laryngoscope was invented, you know something happened around here. This fantastic love affair between the fibroscope and direct laryngoscope, and all of a sudden we saw pop up videolaryngoscopes, all better than the other ones. The other thing which revolution was there, all of a sudden we understood that by sharing the view, something else was coming even more important. It was the performance of the team. So we are opposing technical skills to non-technical skills and human factors. And this was only because, or most of it, because we were sharing the view and everybody could actually see what was happening. This is the just published Swiss airway guidelines. We allocate specific tasks, skills, and then we integrate that because we share the view with a team approach. Stop, share, analyze, brief, debrief, etc. And I think it's a fantastic graphical way to understand how the dynamic approach to the airway can include technical skills, non-technical skills, and it's a dynamic thing. It's not only you go from up to down, you push, it's much more dynamic, you understand, and you get the input from the whole team. I think seeing is believing, and we all here, we believe. What I have personally understood is that by seeing what I'm doing and seeing what the others are doing, I'm much better at understanding what's going on. And if seeing is believing, understanding is much better. And this is what VL allows. I would take as a home account, say, VL, how about routine? And DL, for some specific situations, might still be necessary. But why shouldn't we go like that? And this would be probably the way to do. It's a happy marriage. Thank you very much.
Hi, I'm Bhav Patel at Royal Surrey Guildford. A question about airway ultrasound in the PUMA guidelines. How many people teach excluding esophageal intubation using ultrasound? I gather that's probably in very infancy stages.
It is, and it is, we say, if you are expert. But there is evidence for it, so we had to include it, as there is for the esophageal detector device. You may never have used one or seen one, but the evidence is there that these work. The ultrasound people that I work with, I'm not one of them, they think it's great. I personally would say I'm not experienced. I would not use it. I would use my fibre optic scope as my to check, and I would repeat my VL. But you're a very good question, but we had to...
I doubt very few airway experts would use airway ultrasound to exclude it.
Although I think the younger generation, dare I say it, are much better at ultrasound than we were. And they, you know, a lot of them are members of ESRA as well as airway experts. So I think there is more, and also we're encouraging them to do ultrasound of the neck now, aren't we, and look at the lungs. So it is an evolving area.
My answer, Bhav, is this session's about routine videolaryngoscopy. So can anyone else ask a question? Alistair.
Thanks very much. Ellen, you'll remember a few years ago people said we're fed up listening to experts and telling us what to do. Now,
just here for the wine then.
The Cochrane Review has kind of suggested that VL is better than DL. The PD Register has strongly proven that VL is better than DL, and yet we still cannot get paediatric anaesthetists to use VL as a first line. So when are we going to how can we change this paradigm so that people now say VL is number one and DL is not? If the experts are just being ignored, how can we change that opinion?
I think we're getting there, and I think, change takes time. In 2015, when we were doing the guidelines, the DAS guidelines, we debated this at length, but we put DL stroke VL. Then the critical care guidelines came out, they suggested VL first. All through COVID, I think we were suggesting VL was better choice for all sorts of the reasons we mentioned earlier. But we're repeating our DAS guidelines, and we were on the fence in 2015. 2022, it'll be interesting, because not only is it experts who kind of think we know it all, but it's evidence. The evidence is coming out now as well that it is better. But I think you can't just change. I think it has to evolve. I think it has to evolve. And if you're very good and experienced and forever used DL, and you're very good at it, you can't see the point, perhaps. So. And maybe because you're not very good at VL, you're probably still better using a DL in those difficult cases, or as first choice, in fact. So, it is until we move over to everybody using VL and realising they can also learn the DL technique with a VL. I don't know if you want to...
That's almost a question in its own right. And I'm going to come to Patrick in a moment, but I can see someone else holding on to the sort of square hairy thing that is the microphone. Question.
Cool. Hi, I'm Laurie. I'm an anaesthetist from Gloucester. My question is related to a conversation I've heard quite a lot in the coffee room about patients with an anticipated difficult airway, and someone saying, rather than doing an awake fibre optic, we'll probably just have a bash with a insert generic name for a videolaryngoscope. Now, how commonplace do you think this is in your hospitals, and do you think there's evidence of people getting themselves in a sticky wicket with this kind of situation?
So if you look at the studies. And I'm going to answer this for a bit. If that's all right. If you look at the study, there is no study that says videolaryngoscopy is perfect. All of the videolaryngoscope studies say there is a failure rate. If you have a micrognathic, morbidly obese person of diminished stature in halotraction, then to say I'm just going to have a dash with a VL clearly is not going to get you anywhere. There is some, and all doctors are highly educated individuals. All anaesthetists are a subset of highly intelligent people who understand physiology and pharmacology. Until we get to this wonderful anaesthetic phase, crack on. And I don't know what it is about the anaesthetic phrase, crack on, but it says, I have this enormous mind. I can understand Cochrane reviews, I can understand evidence, I can understand risk, I can understand human factors. But because it's 4:10 in the afternoon, I'm going to just crack on. And all will be well. It's not about... if you go back to the Danish database, and I apologise for any Danes, I can't pronounce Norskov's name right, it's got one of those funny O's with a line through it. But he said the majority of intubations of difficult intubations are unanticipated. And that's kind of where VL steps up to the plate. Because the number of first pass success with a videolaryngoscope goes up. Your chances of a failed intubation goes down. Like I say, if you have a morbidly obese, micrognathic, person of short stature, in halotraction, please don't use a VL. Please use something else instead. It's not about saying VL is perfect. It's about saying VL narrows that gap between being in trouble with an airway to being in less trouble. But it doesn't say you can take all of your clinical skills and intelligence and throw it out the window. And I don't know why it happens. It's a human factors phenomenon that even Fiona Kelly can't answer me for. So I don't know. Panel, what do you think?
Well, I'll let Patrick answer in a second, because I think his data demonstrated the fall in flexible bronchoscopic intubation, and I'm sure he can speak about that. So it is one of the limitations of VL, isn't it, is that it gets you out of more trouble, and therefore there's a potential for people not to do a flexible bronchoscopic intubation when they should. I think we just have to keep banging on the door and saying and teaching everyone, when you think there might be an indication for doing awake tracheal intubation, then take that opportunity. Because I think the case that you describe, the situation you describe, is because that individual has a bit less confidence in awake tracheal intubation and a bit more reliance, dare I say, over-reliance in videolaryngoscopy. And because most of the time it will get you out of trouble, even more than Macintosh, most of the time your confirmation bias will say, yeah, I was right, I got the tube down, it's all fine, until it's not. And you're right to highlight it because it's a real problem. So I keep trying to tell, if a trainee ever comes to me and says, I think this patient needs an awake tracheal intubation, I don't say they don't. I just go, that's great, let's do that then. And I think we all should be just saying, and if anyone ever says to me, look, the laryngoscopy was normal, we didn't need awake tracheal intubation, I say, no, that's outcome bias. You need to have 19 out of 20 or 49 out of 50 attempted awake tracheal intubations that perhaps weren't absolutely necessary for the one to be necessary. So we just need to keep on banging that drum that says, do awake tracheal intubation. It's not difficult.
But while Patrick is ready for his answer, Barry, I'm going to ask a question that naturally follows on. How many of you do awake VL? Excellent. You don't. Barry, tell us a bit about awake VL.
It's not that difficult. The first time I ever did it many years ago was I prepped the airway, about to do an awake fibre optic, awake flexible bronchoscopic intubation, and then Andy or somebody equivalent turned up. In fact, I think it was Pete, Andy, who turned up and said, oh, can we do awake videolaryngoscopy with the McGuire Series 5? I went, yeah, okay. So I prepped the airway, I think it'll probably work, and just went on and did it, and used my generic GA skill to do it, and I thought, this is pretty easy, and then just carried on from there. So I think it feels like a skill you can translate. You've got awake, flexible bronchoscopic intubation, you've got VL skill, marry them together and crack on. And as you heard today at the talks, there are several indications when I think it's a really excellent technique. Sorry, I'll shut up.
That's right, I understand Patrick has got something to say, but he's so polite. Swiss people are so polite. Thank you, Patrick. Whisper a bit. What's something to say? Patrick.
You know, I'm Swiss. Switzerland is the middle of nowhere. It takes you two attempts to come to the UK, right? Because first you forget your passport, then you're dressed well enough, then you... Okay. So we don't do any awake intubations anymore. Maybe because of my understanding of the language, we do spontaneously breathing intubations. But patients are actually asleep or just sedated. So from my understanding, they're not awake, they're just spontaneously breathing. And what we do then, but again, it's a Swiss way, right? We just do diagnostic VL. Try to better understand what the problem is, and depending on what we see, we'll act. Either we paralyze, or we say, ooh, we need a specialist, and we call our friends, etc. So the challenge is, do we do awake? I'm sure many people do it. In Switzerland, we don't do it, because my department is 120 doctors. If I want to train all of them, that's doable. If I want to keep them good at 3 o'clock in the morning in stressful situations with people they don't know, I challenge that situation if they're going to be on top of their competencies. So we designed a different way, which is doable. You can train it on every single patient, self-restraint, spontaneously breathing, etc. You can train it on anybody, and then he's spontaneously breathing. And then you do a diagnostic, and then you decide which way you go. But that's the Swiss way, and that's why you invite him.
Even for a big supraglottic mass?
Well, then you understand what the problem is. You would sit him up for the gravitation to fall down, and you go from the front to have a look. And then we'll do it combined, VL and fiber, but spontaneously breathing open.
Asleep. Though.
Yeah, asleep, yeah. But spontaneously breathing.
I think it's interesting.
That's very different, yeah.
Ella and I thinking, no. But Patrick is a fantastic anaesthetist, and he does it, and if he had disasters, he would admit to it.
Yeah. And I could show you many pictures of disasters. None of that, though, because I don't record them anyway. No. No. But again, I mean, remember in what kind of institution you are. When you have 120 doctors to train and to keep good with strategy, and the Swiss patients, if you walk up to them and say, hey, you're going to be intubated awake, they say, no. So it also takes account of where you are and what kind of patients you have.
Any comments from the floor?
Maybe it comes back to this decision about cracking on and as Barry said, this decision-making bias that's there. And relating to that talk we had about the legal issues, I think one thing to teach is this. I think some of the Rona Flynn and Steve Schoettker, the non-technical skill guys, talk about the pre-mortem, which I think is actually can be a bit defensive, but it's quite a nice way of thinking, is if this all goes horribly wrong, what are people going to ask? And I think if we teach that to our trainees, people are going to say, you had that fibre optic scope available to you, you had an awake technique available to you, what made you not use it in this case, then I think it might lead to a bit of over-defensive practice in some circumstances, but at least it stops you from that phrase of cracking on.
But if over-defensive is safe, then surely that's okay.
Yeah. So I wonder that concept of pre-mortem might be something we should really encompass in our training.
Anyone else with a comment? Or a question?
To Patrick, you said that there are specific indications for DL at the end of your talk. What would you see as being the specific indications?
Well, I expect if it's massively bleeding, you would have a high chance of obstructing the optics. And if you have a hyperangulated blade and your optic is obstructed, it's going to be a pretty reddish view. So it's going to be difficult to understand where you want to put the tube. So that would be an expectation that I would say, I try to understand the problem. I try to choose the best tool. And if there's massive blood or any massive secretions or I don't know what, or I have somebody who has never used the VL. It also goes, it's not only the device, it's the team approach, right? So some people have never trained in that specific situations. I would say in your hands, this device would be the best, would be the DL. And that's, although I'm become the head of departments, I still have many people who use DL, and I say, in your hands, this is the best device for that kind of patients. So it always comes up to the team.
Just while we try and find another question, I'm going to ask you all a question. How many of you think that the latest Copper review, and I bet you a handful, and how anyone wrote 590 pages on little diamonds saying that videolaryngoscopy was better is beyond me, but it's an awesome read. Any of your departments starting to change practice because of an evidence base? If we were cardiologists and there was a new drug to treat an eye, and the Cochrane review had come out, we'd all change practice like that. Are we changing practice, or are we entrenched in our beliefs?
So I work in East London, where we have a non-English speaking high, and I'm also an obstetric anaesthetist. So it's a double whammy. So BMI 50 is like kind of normal for us. So we've now started, haven't written it down. Will probably write it down in the next future. What you mentioned resonated very much with us. It's for the unanticipated emergency, 2 o'clock in the night, when the consultant or the expert is at home or 20 minutes away. The trainees will have to deal with and as soon as they see the larynx, there is that immediate moment of confidence within the ODP and the team that it's going to be fine, and that videolaryngoscopy. So we are now recommending that all obstetric GAs are done with VL to begin with. I think I'll have it written down after discussing with my colleagues as the obstetric anesthetic group.
More about that tomorrow in the last session.
So tomorrow's last session with Professor Mushambi is obstetrics.
So I'll ask the crowd for some opinion. Do you think then the easy target is to say that all obstetric general anaesthetics should be done with a videolaryngoscope to facilitate tracheal intubation?
I think there's a growing argument for that. The same as ultrasound in the spine. I think these are the two things. The way I see it, it's here to stay.
Okay, there's a question. There are 2 questions coming behind you, but I'm just going to ask everyone to exercise their arms. Should we be saying that videolaryngoscopy is the way to insert the tube in obstetrics? Vote yay with this hand. It's not a universal statement, but it's definitely not bad. There are 2 more questions.
So my name's Kate Theodosia. I work up in Scotland, in Edinburgh, in a big obstetric unit in the Edinburgh Royal. And what's really helped us to increase our uptake now to almost universal VL is a checklist, something as simple as that. So for us, we were very fortunate Mary Mushambi generously shared her checklist based on the DAS OAA guidelines. And in that checklist is VL recommended first line, and we've seen our uptake go from 60% up to above 96% over the space of about 2 years. So it's made a big difference. But we're a big hospital, there's about 80 consultants, and I'd say there's certainly definitely not universal VL across the corridor, but in obstetrics we've made big inroads and with good outcomes. Yeah.
And Kate, I would just ask you a follow-up question because I can. Have you noticed a change in your first pass success or intubation success using a videolaryngoscope?
We have, yes. We
just like the Cochrane review then.
We have, yeah.
But I think it's the human factors in obstetrics. The stressful caesarean section in the middle of the night in a fat patient with the obstetricians losing their heads because they've delayed the section you know, and you have a junior anaesthetist there, and hopefully maybe a senior ODP or whatever. Yeah. But I think everything that can help, you should have. I personally think you should have Thrive on the patients as well. You should, because you have a spare pair of hands. And do you? Brilliant.
You're using simple nasal cannulae. 10 litres,
nasal cannulae, exactly.
We get about 1 or 2 Cat 1 GAs per day. So we have the nasal cannulae ready to go. Pop them on 10 litres, mask over the top, so that while the patient's giving you their allergy history, having their citrate, they're being pre-oxygenated, you can face mask over that. And then we get the ODPs to do the checklist. So it gives the junior anaesthetist time to calm their nerves, gather their thoughts, give them some headspace to perform well, and it gets the ODP on board with the plan, so it seems to be working well. Yeah.
There were some more questions. Someone's pointing at someone who's
Anil.
got their hair. Oh, dear, Professor Patel. Right.
You can answer your own. You can answer your own question. I'll ask you a question. How much did that bike cost?
So, great talks. So I wonder whether actually there is an element of entrenchment in anaesthetic practice, actually, and it's not us. So we don't need to convince ourselves. We for 20 years we've been going around saying this is wonderful, this is great, this is exactly how we should do it, and that's what we all do. But we're not talking to the right group, because this is a relatively small group. The bigger group out there, I'm not sure we've made a little bit of impact on, but the vast majority are still using DL. If I look at my department, we've got VLs everywhere, and the only time they really get a VL out is when they're predicting something's going to be difficult. Often, not everyone, but quite often. Many of us use it all the time for everything. So the question is, where is that tipping point? Where is that transition from people that are interested in it and enjoy it and recognise its usefulness? How do we push everyone else? Goad, support. How do we transition? Now, are there any German anaesthetists in this audience? Good. So if you were... So one way to do it, and it works, is if you go to a department in Germany and you're the head of the department, you say, we're all going to use VL. And everyone goes, yes, sir. And they all use it. Now, we don't do that, do we? And that's a good thing. But sometimes it's not a great thing, actually. Sometimes you need a push. I would have thought by now, 2022, we would have had that push and we would have transitioned over to all the people that are out there not sitting in this room would have got it, but they don't. The other thing that's slightly concerning is we had this great push for VLs during COVID, but we seem to have had a retraction from that as well. So I think we've still got quite a long way to go. Now, the things that are going to help that process are all the guidelines and all the documents that come out, the PUMA guidelines, all the reviews, everything saying conclusively, this is what you need to be doing. And we need to get to a point where maybe not 50%, but a significant percentage of the anaesthetic community go, this is definitely the right way to do it. If I'm not doing it this way, then somehow I have subnormal practice. But I don't think we're there. We're there in that conversation between all of us, but I don't think we're there out there. And similarly, how do we make that process? How do we speed that process up to get to that point?
Surely we just keep banging on the door. There's no magic wand, magic bullet. It's just we just keep on and on and on, because the naysayers are going to get fewer and fewer until there's enough head of steam. You know, I'm amazed that lots of my consultant colleagues do not have hyperankulated VL in their armoury. They just don't even have it. And I think, why not? Well, I just don't really need it. But you might just need it once or twice. It's not difficult. Just practice it now and again and you can have it. But they don't. They choose not to.
I'm not sure it's helpful to sort of point the criticism at individuals. I think this is a symptom of a culture in healthcare that just happens to come out in this way. And I think that culture is of ego, of if I pick up that thing, I'm not good enough at the direct, it shows. And it's also very little things. I'd say, and some of these barriers sound small to lay people, but when you're working with ODPs who have to clean it, and you say, I want the VL, and there's a little eye roll, that actually has a massive, massive impact. So I don't think we can have this conversation in isolation either. We have to have this conversation with ODPs present. And I'd say it reflects the culture in our meetings, in our day-to-day lives, in everything. We have to flatten hierarchy and involve a multidisciplinary team and look at all the cogs in the wheel and not just point blame at individuals.
But my experience, you're absolutely right, but my experience, if you involve the assistants in the intubation because it's VL, they actually get more into it. So actually, they should be into it, because rather than just handing you stuff.
There should be, but there's like this, it's even if it's a perception, there's this slight I'm going to have to clean that now.
Yeah.
You want everything, don't you? This kind of, and it's just a joke. It's just a joke, but actually that has a huge impact on behaviour.
One of the results we can give you from COVID, because I can see Kareem at the back, an intubate COVID result, 80% of intubations were done with VL. Prior to COVID, 30% of intubations were done with VL. Post-COVID, 40% of intubations were done with VL. So the spike kind of went up, came back down. Some more questions?
My name is Nada. I'm an airway fellow at St. James's Hospital, Dublin. So I have a question now. Everybody's clear, okay, VL is better than DL. Okay, we agree. But now an individual type of VL makes a difference. I mean, the view is good with all of them, the hyperangulated or McGuire, whatever. But for me, I find the tube delivery is different for each gadget. And there have been times when the hyperangulated blades were just being introduced. The tube delivery was actually difficult, so I always preferred my DL to intubate. So what's the recommendations on the use of different VLs?
I'm going to go back to Patrick and ask, how do you teach VL to your trainees?
Think about in which department you are and the size. In my department, when I use VL, I only use hyperangulated, because at 3 o'clock in the morning, they're not able to understand what kind of blade they have. And if the blade is direct or Macintosh or hyperangulated, the technique you use, the tube, the delivery of the tube is very different. So I minimized the cognitive overload that they already have when they can't intubate, can't oxygenate, and they take a device. And then we go through teaching. So we only used one device, only one hyperangulated blade, and I had some specific requests. I wanted to have a big screen. I wanted to be able to record. I wanted to be able to send it over to all my friends. So that made me choose my own device for my own institution with the team I had around it.
And what adjunct do you use for the tube delivery? Like, there are countries that have a starlight culture, and the others are bougies. So.
Yeah, so there's a little conflict of interest because I use a device that I designed. I won't tell you the name.
Most of us that are using hyperangulated blades would say that with a hyperangulated blade, you have to have some sort of stellette and curved to the shape of the blade that you're using. Otherwise, you're not going to get the tube in. And maybe that's our teaching fault. But with time is pressing on, and I want to get as many people with comments, maybe people that haven't participated up until now, with things they want to say or questions they want to address.
Yeah.
You have had 2 goes. Yes, you're absolutely right. Because one of the goes second.
I just wanted to make one point towards what Ed had said about regard to the whole multidisciplinary team. 10 years ago, we brought in McGrath Mac, and it was not us that chose to get more of them. It was actually our theatre manager, who was an ODP, who suggested that we need more of these. It was not us, so therefore 99% of the intubations that happen in my hospital are done with a videolaryngoscopy, and that was because of the theatre managers wanting this. They don't care. I anticipated the cleaning problems and all these things. It doesn't happen. They don't mind doing it because they see the advantage. Well, one question I was going to ask Barry is, one of your questions about which device do you choose? My problem, and probably more your problem, is that when you work in a hospital that does both children and adults, which device do you choose and which size do you choose? That is always my problem, is that because most of the devices come in a variety of sizes, it's not only the device you choose, it's the size of you choose. So what you really need is something which covers all sizes. Would that be anything you would agree with, or? So
just for the audience, so you're clearly a paediatric anaesthetist.
I am a paediatric anaesthetist, sorry, I work in Edinburgh as well, so I do apologise.
Do you want me to answer that?
Yeah.
Yeah, I mean, my paediatric practice is Macintosh VL with the appropriate size sheath. I don't use one size for everyone, like you wouldn't want 7. And I go down to really small ones with that on the basis of your work. And then if I'm in difficulty, either anticipated or unanticipated, I'm going to use hyperangulated. But that's the same for my adult practice. And going back to your question, I feel strongly that Macintosh VL should be the basis. I think trying to convince everyone out there to go straight to hyperangulated is pie in the sky, no chance.
I do too.
One
Sorry,
step
yeah,
at a time. Start
absolutely.
at Macintosh, and I'll be quiet.
No, just because, I mean, I know Al has done some great survey work, which isn't quite published yet, but the VL IQ stuff. What's the percentage of people in the whole of the world, actually, using hyperangulated VLs?
I can't quite remember the numbers, but I know that the top three, top
7
four
to
devices
4.
were all Macintosh shaped.
Shaped, yeah.
And the hyperangulated blades were actually beneath.
Beneath.
And that's, the airway community has been saying for years, you know, Chris Frog stood up in WAM in 2015 and said, I was always use anything hyperangulated in a videolaryngoscope. I don't think the rest of the world are there yet.
No.
And I don't quite know how we get them there. I don't quite know whether we need a college edict to say everyone should use videolaryngoscopy, but the college won't say that because they can't dictate NHS budgets. I don't know whether it's going to take, sadly, a trip to court where there's been a misadventure and people say that that's going to change practice. I don't know. The evidence is pretty clear. You know, a Cochrane review that says you will reduce the incidence of failed intubation by 2/3, from 3% to 1%. It's difficult to argue with. I've got another question. Excellent.
Hi, sorry. I'm a senior trainee up in Dundee, slightly not quite a consultant yet. From a training perspective, as a senior trainee in 9 Wells, I can be called to anywhere in the hospital to do an emergency intubation. And there is no guarantee that I'm going to have a videolaryngoscope to hand. Is there a role for training us in both until we can guarantee that in an emergency intubation, I'm going to have immediate access to a videolaryngoscope? Because I don't want my 3 o'clock in the morning intubation on the dialysis unit, which is about as far away from my nearest videolaryngoscope as I can get in 9 Wells, which is probably a good 10-minute walk, to be with doing direct laryngoscopy and a piece of kit that I've not used in quite some time. Because I agree that videolaryngoscopy is great and we should be using that as our first line. But I don't want to be de-skilled.
I think you have to be skilled in DL, and we have in that technique, because all our trainees in Ireland, it's a national rotation, rotate around the country. In fact, almost too much. Every 6 months they need to go to a new hospital, even a new area. They'll have different VLs in every one. They'll maybe or may not have a hyperangulated blade, but they will have a DL everywhere. And if they go down to the A&E department, some will have, we probably have, I think, Nori with them every site now, but in some hospitals they don't. So it's very important that they're all taught the DL. Whether you teach it, though, with a DL or with, with your VL, that's the point. I would think we should still we still have DLs in our theatres, unlike Bath. So we do teach both. Look, we're anaesthetists. Does a surgeon say I only do one operation? I mean, we have to learn DL, we have to learn VL. Hyperangulated, I think we like to do, but it's a stretch too far, perhaps. And you talk about cognitive overload. But equally, shouldn't we all be able to do DL? Hands up here who doesn't do DL. I mean, we can all do DL, we can all do VL. We should all be doing hyperangulated VL. We should all be able to do an awake fibre optic intubation. That's it. That's it as an anaesthetist. But, how many surgeons do 5 operations? Do they do a lap chole and say, what goes wrong, I can't do an open chole, which we have to do recently?
It can still be routine VL. You can still have routine VL, as Patrick demonstrated, and maintain Macintosh DL as a skill, even if you're first line.
Absolutely.
Would you agree?
But I think you then need to, having been in theatre with consultants who use VL, I think you then have to be very cautious about the fact that there are some people who just do VL and don't do DL at the same time. And I think that you have to be very careful what we're teaching trainees.
I agree.
So the college in COVID decided that you could learn both VL and VL skills with a VL. And I wonder whether that's a failure of your trainers rather than a failure of your skills, because actually you can teach DL with a VL.
Alistair, when you say failure of her trainers, who are you thinking of?
Barry, I think we'll pick up that VL, and that. You see, what you need to teach the trainees is that when you go to the on-call room, you stick that in your pocket, and then wherever you get called to in the hospital, you have a VL capacity. There are some, like Higgs apparently has a microphone. Should we let Higgs speak?
No. Okay. I don't have a question, just an observation on the sort of natural history of revolutionary thought. And what happens is that when someone introduces something new, people talk about it and grumble about it and disagree about it. And then as the new thought gains traction, then maybe people get a little bit more aggressive and a bit angsty about it. But then what happens is that usually the resistance goes up and up and up and then disappears. That's the natural history of a lot of revolutionary thought. And I think we're now really getting into the skirmish. We've been talking about this for a while. Now we've had the Cochrane review with hard data, and we can talk to people saying this is the data, it's clear now, we're getting guidelines saying routine VL. So I think in the next 2 to 4 years, pick a number of years out of the air, but for the next few years we're going to see an increased degree of resistance, but I predict that very soon after that it will just go and VL will become routine. But that is my prediction for the future. Observation on life, prediction for the future.
Well, it's on video now, so we can come back in 2 or 4 years and see how true it was. Kareem Al-Baghdadi has his hand out at the back. Professor, what would you like to say?
Thank you. I'm just Kareem, firstly, from London. I loved the story of the dialysis unit and the intubation, because there's multiple levels of complexity there. I think that what we need to start to think about as a group of enthusiasts is the idea that direct laryngoscopy is an advanced skill and videolaryngoscopy is a basic skill. And I think that's maybe how we need to start to reframe the discussion. Now, Ellen gave a really lovely example of the surgeons that could do 5 operations. I'd love to see your surgeons, Ellen. They might be slightly different in London, but there's laparoscopic surgeons, and they can't do open procedures. And I think we all probably know people who know surgeons or have worked with surgeons who can only do laparoscopic surgery. And previously, laparoscopic surgery was an advanced technique. And, the traditional surgeons would use a big incision and open everything up. And the concept of using a camera to perform their surgery was suggested that it was an advanced technique. Now, opening the patient up is an advanced technique. And I think that once we make that shift in how we view it, then we will be able to bring people along and have them believe, okay, you are an expert at this advanced technique. Now let's get you to be an expert at this basic technique as well. So I think that might be one way, Anil, of us moving forward.
I can see that time is ticking on. I want to get as many people involved as we can. So we kind of speed up contributions. One just here.
Very quick question then. Do you think the heterogeneity of the studies included in the Cochrane database was a flaw? Including those kind of studies which have occasional intubators rather than what I would like to think we all are, which is frequent intubators.
Do I want to criticise Jan Hansel's 590 pages? No, not today, not any day, because there's no way we can. Cochrane reviews are designed to take into account the heterogeneity, and you can look at the I-squared statistic for their forest plots. It's remarkably robust because of the numbers. But, yes, nothing is perfect. There isn't a big VL study. We're waiting for the MS study to publish. It's the biggest one there is, and yet it hasn't made it into a journal, as we'd call it, yet. So big studies would be better. We don't have any yet. Someone else? No one else? Yes, sorry, please go ahead.
Just one quick question. You guys are respected experts, and now have you standardized or kind of insisted that one particular type of VL is used across your hospital or trust? Just out of interest.
I'm always of a view that we should, we're a big teaching academic hospital, one of the biggest in the country, with a huge range of surgeries. No, I'm the opposite. I think everybody should be able to do DL, AVL, whichever one we have, which is true, because they move on, as I say, and also we always use channeled as well to teach.
So you have multiple types of
catheters, and we use 8-wake fibre optics. So no, maybe because of where I work, but I take your point on board as well.
Yeah.
That but our trainees rotate a lot. They do 7 years training. They all do a fellowship. So that maybe we're developing kind of experts a bit, really. I don't know if you was just train in the one hospital and stay in the one country. It's a different training system, maybe.
Our physicians, they rotate around the different states, and we decided to go one device hyperangulated and one device with a channel. So they get philosophy, and then we teach them the specifics of each technique because it's a different technique. And just to reply, when we introduced VL, we used to do first DL and then grab the VL and have a look. Now we changed it. Now we go routine VL, and then, hey, you want to see how it would look like with the DL? Go have a look. And then when we go back to VL, we see all the little bleeding that was done by the DL, and this is very convincing.
Thank you.
You certainly don't want people using devices that they're not familiar with.
Yeah.
So look at what you've got. If you've got 10 completely different video laryngoscopy, I would say that's the wrong way to go.
Yeah, amalgamate. Certainly in Edinburgh, where I work, we went for a universal McGuire strategy.
Yeah.
Not because it's perfect,
No.
but because actually by getting everybody using the same thing most of the time, then we had an institutional memory, a corporate memory. Our anaesthetic assistants were used to using the device, helping people use the device. And I still remember once on the evening where I was called in to do a laparotomy. There was no trainee. And I raced ahead and put the videolaryngoscope in too far, and it was my ODP who said, pull out. I was in that kind of zone of bloody doing a laparoscopy at 10 o'clock on a Sunday night. I don't know whether that's freeze, flow, or frazzle, but it was actually just that word of wisdom from someone who'd seen it done before that mattered. And if I'd been using the 10th different device, I'm not sure we'd have had the same. Exactly. Any more comments before? I'm kind of hoping someone's going to wave the buses are here.
Sort of thinking about what Ellen just said along the lines of trainees and rotating and things like that, I actually see that as a potential way forward in that I work in a DGH adjacent to Edinburgh. We are definitely not on the VL, as a department, the consultants have been asked about who would and wouldn't do VL first off, and we're definitely not there yet, even if the evidence is. But what we do have is trainees coming from elsewhere, which is modelling good work, like your obstetric checklist, which states things like VL and things like that. And when the trainees are asking for it, the ODPs are getting it out and are wiping it down and are realising it's not as bad. And then the ODPs are liking it, and then they're offering it as a suggestion. And those of us that are a bit younger are like, oh yeah, I do actually quite like using the VL. We'll use it a bit more. And I think that kind of trickle down from areas of wide use via the trainees and back through the ODPs into the people that are maybe a bit more fixed in their thinking will be one way that this sort of, that we follow the evidence in that sense as well and move forward from that, so yeah.
Never did I think a Liz Truss phrase be used in reference to videolaryngoscopy.
Not deliberately.
It is now 8 minutes past 7. I'm told the buses are here at 10 past. It's my opportunity to wind up and say the Cochrane Review is there saying videolaryngoscopy is better than direct laryngoscopy. The PUMA guidelines are saying that everybody should use videolaryngoscopy first line whenever possible. I think this room has got the message that videolaryngoscopy is better than DL. Our challenge is to bring that message home to departments and to benefit patients. On your behalf, I'd like to take the chance to thank Medtronic for sponsoring the evening. Please make sure that the table at the back is empty before you leave, and please all have a great time with the dinner. We will see you at 8:30 in the morning at the DAS AMM.